मैं वो
Hi, good evening,
Hi.
everybody. Hi, Farul. Hello, Dr. Rita. Hello, Dr. Nisha. Hi, Dr. Nisha. Good evening, everybody. It's indeed a matter of great pride for all of us here at IFS Quiz Committee to be welcoming you all on the sixth episode of Genius Junction, which is the online quiz series of the Indian Fertility Society. So today's episode is dedicated to the very important topic, which happens to be less addressed, and that is fertility preservation. So we have with us two stalwarts who would be talking about the medical aspects. Dr. Rita Mahi from AIMS, and the surgical aspects, Dr. Nisha Singh from KGMU. Dr. Nisha Singh happens to be the head of the gynae oncology department of KGMU. She's a very, very learned clinician and a very, very thorough, gentle lady and a very wonderful human being. It's really a pleasure to have you on board with us, Nisha. And your talk would be followed by Dr. Rita's talk. And then we would have the quiz on Kahoot, which Dr. Divya Agarwal, she's a very renowned fertility specialist in Varanasi, and she would be taking the quiz on Kahoot. So, without any further delay, over to you, Dr. Nisha.
Thank you so much, Dr. Manjusha, for making me part of this program. And I'll just share my screen. I hope I'm allowed to do so. Okay,
Of
yes.
course, of course.
Yeah. Mm, okay, just a minute. Okay, can you see my screen?
Yes, Nisha, we can. Yeah.
All right. So, the topic that has been given to me is fertility preservation surgeries in gynecological cancers per se. So, as you all know, that this is an important aspect whenever we talk about cancer and fertility together nowadays, because of the increasing number of women having the disease in earlier age group, more and more adolescents and young individuals, the burden of infertility as a cancer complication is actually increasing. And but then it is a preventable problem. We can do, if not everything, but something about it. So cancer can affect fertility by basically because of the removal of the reproductive organs or due to the effect of chemotherapeutic agents or radiotherapy. And the impact will depend upon the pre-treatment fertility status and the age of the patient, type of cancer and the type of treatment, the various drugs and the site of radiation. So we have surgical options and medical options. I'll be dealing with the surgical options that are available to preserve fertility in some way or the other. So what are the fertility surgeries? Then there is something known as ovarian transposition and oophoropexy, and also uterine transposition, which has come up now. So just an overview about the fertility preservation surgeries. For ovarian cancer, when it is early stage, stage 1 epithelial cancer, then the borderline ovarian tumor, germ cell tumors, sex cord stromal tumors, for all these in the early stage, we can go for a unilateral oophorectomy and it a comprehensive staging. In cervical cancer, up to stage 1B1, we can offer some surgical procedures like conization, radical trachelectomy, simple trachelectomy. For CA endometrium, I won't say there is much surgically, but medically that's available. And then ovarian transposition, oophoropexy, and uterine transposition are actually useful whenever radiotherapy is given either for CA cervix or CA endo or for the GI cancers. So the first and foremost thing, how to decide about which case can be taken up. It's very important to go through a detailed history and examination. If we talk about CA ovary first, a good imaging, which could be a CECT or an MRI, depending upon early stage or advanced stage, and then the tumor markers, which I have listed here. The whole panel should be done because we miss on certain things, and since we are talking about fertility preservation, so it is young age women, so all of them, CA125, CA199, AFP, CEA, beta HCG, LDH, inhibin B should be done. And then only when we find that it is an early stage disease, we can plan a fertility sparing surgery. But the tissue has to be, the mass that we remove has to go for frozen section. And whatever result comes according to that, we can actually decide that yes, this can go for a fertility preservation. Yet the final histopathology will actually might change our thoughts. So just presenting one small case, the 17-year-old girl who came with heaviness, pain and abdominal distension for 2 months with a solid cystic hard mass, a big mass, 13 to 30 centimeter, restricted mobility, lower margin not reached. And on the CECT, it was a similar size mass and a complex left ovarian cyst. Here, she had two tumor markers raised, CA125 and CA199. And so a fertility sparing staging laparotomy was done, where we did a left salpingo-oophorectomy, infracoelicomentectomy, and peritoneal biopsies. And we sent the mass for frozen. And you send it for frozen, and in the meantime, you do the staging part, that is the biopsies and the omentectomy. It turned out to be a benign on the frozen. And then the final histopath that came, it was a mucinous cystadenoma. So though the markers were raised, but with this approach, we could save her fertility completely. So this is the case. You can see these pictures of this huge tumor. It weighed, I think, some 7 kg or something. That's how it was. So for CA ovary, as I said, in the stage 1A, that is when it is limited to one ovary, the mass is limited, then this comprehensive surgical staging can be done. And in these cases, you can do, it's only in, that is for the epithelial ovarian cancers, but for the germ cell and the sex cord stromal cell tumors, even in a little advanced stage, because they are very good chemosensitive and they have very good response, you can do even in the further stages also, if she's a young girl and needs. Then the details of what we call as comprehensive surgical staging. I won't go into the details in this session, but just to tell you that what is staging laparotomy and what is cytoreductive surgery, just to understand. So staging is when it is an early stage disease where we are doing the peritoneal biopsies and omentectomy just to know, is there any microscopic disease beyond what we are seeing? While in the advanced cases where the disease is already macroscopically visible to be advanced, it is known as a cytoreductive surgery. Malignant germ cell tumors, as I said, because the dysgerminomas, immature teratomas, yolk sac tumors, they are all very chemosensitive. They have markers which are very specific. So in these cases, we can do even in the beyond the stage 1A also, stage 1B, 1C also can go for the fertility sparing surgery. And even in the stage 2A, you can actually, it depends. I mean, the debulking will have to be done if the other ovary is involved, but if one of the ovaries is normal or even a partial thing can be done. Similarly, but with the immature and the yolk sac also, but in those, they are poor prognostic tumors. So all the counseling and consents have to be very clear. And then only we should go ahead with this kind of approach. Sex cord stromal cell tumors, because the granulosa cell tumors and certainly leading cell tumors do occur in the young girls, the juvenile granulosa cell tumors. So here there is a role of considering this. Now remember, all these histopathologies will come up only when you send it for frozen. Otherwise, you cannot know which type of cancer it is. So you have to have that facility if you're thinking about giving a fertility preservation option. Now, this is another case that we just did. These are all within the last 5 months. A 19-year-old with very obvious signs of virilization, amenorrhea, inhibin, CA125, CA199, AFP, testosterone, all were raised. And we did a fertility sparing surgery. You can see the pictures and imagine what big. And she even had one in the other ovary also. So I just did a cystectomy on the other side. So one side whole tumor removal and the other side a cystectomy. And the final histopath was a certainly leading cell tumor and the other side was a corpus luteal cyst. So here we could really preserve her one ovary and the uterus. And she came post-op. She started menstruating. It was such a delight, she was so happy with the surgery. And then since it was again limited to only one side, we did not, need any chemo and all also for this. This is another 11-year-old girl who had come with heaviness and pain abdomen, just 11-year-old, and she had so many tumor markers, race CA19-9, beta HCG, and even LDH, and this turned out to be on frozen. It was a possibility of stromal tumor, and in final report, it was a juvenile granulosa cell tumor, and we gave her a fertility preservation, did not even need adjuvant chemotherapy. Now, coming to CS cervix, where fertility sparing surgery is an oncologically valid alternative to radical hysterectomy for young patients, but it depends what is the stage of the disease is very important. And a good counseling, that the risk of fertility sparing therapy abandonment may be there. There may be positive resection margins. There may be lymph node involvement. So what we are doing today in the surgery doesn't mean is final. It's only what we remove, and then what the final histopath says, we'll have to go to that. So the patient should understand that it is only a trial of giving a fertility preservation. So not recommended for uncommon and rare histological types. It's only the squamous and the HPV dependent tumors that you can go for it. A pelvic MRI or expert sonography are mandatory. We have to know that how much is the uninvolved cervical length, and what is the remaining cervical length after you have done the fertility preservation surgery, like the cone or the trachelectomy. So these are the options: the conization, simple trachelectomy, and radical trachelectomy, which can be done vaginally as well as abdominally. The goal is to resect the invasive tumor with adequate free margins and preservation of the upper part of cervix, some amount. That is the aim actually. And you can see the indications. So conization is done in stage 1A1, 1A2 with whatever LVSI stages. But if it is 1B1, then the LVSI should be negative. Similarly, for simple trachelectomy and also for radical trachelectomy is needed for 1B1 disease with negative or positive LVSI. So what is the cone? We are actually soon doing in July one live workshop on where we are going to show this procedure particularly, because I think very less people take use of this cold knife conization or cone biopsy or conization, whatever you call it. So it is a small procedure where if you can see in the picture, the cone is removed, which has its base at the ectocervix and the apex at the level of the internal os or a little below that. And it is done without using cautery, because the advantage is that the margins are very, very clear. They can be assessed by the pathologist. And only when the margins are free, you say that it was a therapeutic cone. And it is both diagnostic and therapeutic. And in early stage disease, this can be an option for women who want to preserve their fertility. So 1A1 and 1A2 with LVSI negative. And the other is the trachelectomy, where you remove the whole of cervix. So here it was the cone and some part of cervix was left, while in trachelectomy, whole of the cervix is being removed, simple trachelectomy, and radical, along with the cervix, some amount of parametrium and the vaginal cuff is also removed. Another thing is that whenever you're going for radical trachelectomy, simultaneously lymphadenectomy has to be done. And if the lymph nodes, actually one should go for this first and send it for frozen. If they are positive, then the patient is not a candidate for um, this fertility preservation procedure. So you have to be sure that the lymph nodes are not involved, disease is not spread, disease is just confined to the cervix, and then only. And the intraoperative frozen may also be done to assess the resection margins. If your margins are positive, then also you will have to abandon, which I said earlier. So these are the options that are there. This is just in a flow chart, the similar thing that can be seen. So lymph nodes are important to be staged once it is LVSI positive or it is 1B1 disease. So yeah, that I have talked about. I think I will just skip this. So if there are tumors more than 2 centimeter, that is your 1B2. Now this is ideally, it has a significantly higher risk of recurrence, and this is not to be considered for fertility preservation. This is very clear. There are only some case reports, some when individual cases when the patient is very much keen, and after understanding all the risk of recurrence and everything, then people have tried giving neoadjuvant chemotherapy, and after that, once the disease shrinks, and then doing the vaginal or abdominal, fertility preservation surgery. So I wouldn't go into much of this, but okay. Then talking about ovarian transposition or oophoropexy. So transposition this is offered when pelvic irradiation is required. So you want to keep the ovaries away from that field of radiation. Now one has to remember that ovaries will not always be protected because sometimes there may be radiation scattered. There may be a risk of remigration. And transposition involves division of the uterovarian ligament and fixing the ovary within the paracolic gutters, that is above the anterior superior iliac spine. Oophoropexy is just tucking the ovary in a place where you think it will not be affected by the radiation. And then, the various factors that need to be seen before this. Now, certain things like the histopathological, it should be squamous cell carcinoma, then the tumor size has to be less than 4 centimeters. I mean, it shouldn't be a disease which is already spread or there is a risk of ovarian metastasis. You cannot do. So it's only in young women where the disease is also early stage. In the old advanced cases, we do it only when we want to preserve the ovaries for the function of menopausal function that can be done. So the principles are that we have to first on the imaging, it should be normal. Then intraoperatively, it should be on inspection, it should be normal. There should not be a suspicion of any metastasis. Bilateral salpingectomy may be added to minimize the risk of ovarian mets. And they are generally placed laterally above the pelvic brim, which I said. Then the surgical clips can be placed at the location of the ovary to help identify the location. And if they are transposed in close proximity of the field, then the dose requirements will have to be abundant, and careful communication between surgical and radiation oncology teams. So basically, radiation oncologists will have to see where it is actually located, and accordingly, there could be some complications like the ovarian cyst formation, chronic pain, torsion, meds. Just showing you certain pictures. There's a video also. If I have time, then maybe, I'll show maybe later on. So this is how the transposition is done. Maybe
Nisha, you can please show the video. We'll be
show.
really interested. Yeah, we
Acha,
want to see the
okay.
video. Yeah.
Okay, wait. Wait, it is moving. I don't know. It was running nicely. It's running. Wait, we'll just wait some time. Okay. So basically, this is the ovarian ligament that is being transected. So you can do it laparoscopically, you can do it open, and then you take it away, the ovary. And you have to remember that the IP ligament has the supply to the ovary, which is not to be clamped. And then you take it and you make a tunnel. Yeah. So this is the tunnel that is being made in the peritoneum. And then there will be coming out into the paracolic gutters. So taking this, so once we, yeah. So here is this ovary and this will be moved through this tunnel that has been opened up. So this is of the, yeah. And then tucking it with a, Prolene suture, non-absorbable suture. And in addition, applying the clips and you can palpate the anterior superior iliac spine and then about 4 fingers above that, in the paracolic region, you try to fix it. So that's how you fix it, and also apply a clip which will be visible radiologically. And then this is the other side. Yeah, I think I'll just move then. So sometimes people do these oophorepexies, that is just tie them in a position they feel it posteriorly, maybe close to the, ovary sutured onto the right uterosacral ligament. So posteriorly, where they think that the radiation will not be there. And then also anterolateral, just above the round ligament. But then I do not know really how much this is going to work, because the radiation scatter which we were talking before, they may be there, and then really to protect them against for fertility preservation may be difficult. So all in all, to say that the awareness about these options, this talk was just to tell people that when you have a case of CA cervix, ovary, or endometrium, refer to the experts so that they can, decide and see and give the options. So that is very important. So first the doctors have to be aware, and then only the patients can be told. A good pre-op workup is mandatory, because to select the patients, there are a number of criteria which the nitty-gritties have to be seen. Choose the right surgery for the right patient. So it is a tailored surgery. This is a time of precision medicine, and we are living in this era that we cannot just do a THBSO for all, or then a good multidisciplinary tumor board or a disease management group has to discuss and then take such decisions. Fertility preservation in a cancers will not be my own decision alone. It should be that the team sits together and decides. There should be a good balance between the gyne-onco team and the fertility experts. Each has to have a good coordination and also given a good independence which is required according to their expertise. Counseling and consent is very important. You involve the patient and the partner also. And those girls or women who do not have a partner, the parents, or they should understand what it is and how it is we are going to do things. And it is possible for CA cervix, CA ovary, which I detailed through the various cases that I showed in the early stage. And treatment completion usually is advised after the childbearing. So thank you so much for patient hearing. If there are any questions, I'll be happy to take.
May I request the admin to unmute Dr. Parul?
Yeah,
Shivam,
Manjusha?
Shivam, please
Can't hear you.
unmute.
We can't hear you.
Done, ma'am.
Yeah,
Can I request Dr. Parul to please take the questions? Yeah.
yeah. I think questions, Dr. Nisha, it's a very amazing lecture, and you have involved all the. It's a very crisp,
I
and
cannot hear. Acha,
you
wait.
cannot hear me.
Wait. Hello?
Hello.
Yeah, it was.
Yeah.
I had put the sound off at the time of the video, and that's why I couldn't neither hear not. Okay, tell
It's
me.
okay. Yeah, it's a very nice lecture and amazing lecture, and it's you involved all the fertility for sparing surgeries aspects, and especially the young females. And also very important that we have to, as you have already said, counseling is very important, and also we have to involve the fertility experts. Sometimes the patients after surgery, they are coming to supposed to me after 3 weeks of surgery, and they are post for the chemotherapy next day. So we also should have a time at least for 2 weeks
Absolutely.
for
Absolutely.
fertility preservation, especially for
Absolutely.
the yeah.
Hmm.
So this is the message I want to give. So let's see the questions. There is one question: in which ovarian cancer is FSS contra-indicated? Uh,
Okay. So,
yes.
as I said, like in the epithelial tumors in general, this is a poor prognosis disease per se. The high grade serous cancers are really, not for fertility preservation, and not for, they should be a complete this thing. Only if it is, you have ruled out it is only limited to one ovary, as I said, stage 1A only. And simultaneously, you're doing the comprehensive surgical staging. So later in the histopath, if it comes that the momentum was involved or the lymph node, then also you have to go back and do a completion. So all that counseling everything has to be there. So the good ones are the germ cell tumors and the sex cord stromal cell tumors, because there they are very they have a very good response for the. So but then if I mean I can't go into all the types, because there are huge number of types of the ovarian cancers, but these are the common ones, I mean the broad categories. So that is how it is. But the rarer ones, the more those with poor prognosis, per se the rarer ones are not to be taken up.
Okay, thank you, Dr. Nisha. Any other question? I couldn't see any question.
Can I
Dr.
make
Maj
one comment, Parul?
yeah,
Actually, I think that we as gynecologists are pretty much sensitized to the need of fertility preservation. But when the patient reaches the general oncologist or a general oncosurgeon, for them, TAH, BSO is one word, and they just finish off with everything in one go. So I guess things lectures like this are more needed for us to be
more needed.
addressing those guys, so that they at least give the option to these small little girls to see a fertility specialist or a gynae oncologist or a gynae oncosurgeon, so that we guys can at least be, trying to preserve fertility for them.
So I think
Actually,
that is the
yeah,
reason that this super specialty of gynec oncologist has come up, because we understand both the aspects best. And
Yeah.
also, I mean, the communication still has to be there, whosoever is doing. So, and THBA, so many times, many gynecs also feel, for everything, there is, I mean, not in younger girls, even in the older age group, there is so much of tailored surgery which is applicable in today's times. It's not that she's just 40, remove the ovaries, or there are a lot of things that can be done about it. So yes,
and
communication and this thing is required. Yeah.
and
And
also
one more thing,
fertility expert should be involved from the day of day one. I mean, that's why we can able to
Yes.
counsel the patient.
True.
Yeah.
thank you so much, Nisha. You have taken us through all the aspects of fertility preservation, the surgical aspects, in such a short time, in such a crisp and comprehensive manner. That's being you. Thank you so much,
Thank
Nisha,
you.
for sparing time for this event. Thank
Thank
you so
you.
much. I would request that you stay on for with us for another half an hour if you can spare time, because the next talk and the
I'll
quiz
listen
is
to
going
Rita's
to be
talk.
lovely.
Yes, sure.
Yeah, thank you so much. So, Dr. Rita Mahi. Dr. Rita Mahi is a professor at All India Institute of Medical Sciences, and she is the convener of the SIG of Fertility Preservation at Indian Fertility Society. And I really have to give a big heartfelt thank you to Rita for so graciously accepting our invitation to be a part of this program. And without wasting any further time, I would request Dr. Rita Mahi to please enlighten us on the medical aspects.
Thank you, Dr. Manjusha. Am I audible and my screen is
Yeah,
visible?
yeah, you're
Yes,
perfectly
yes,
audible, Dev. Yeah,
Okay.
yes.
thank you so much.
Thank you, Dr. Nisha, for excellent talk. I think I will cover the fertility preservation when and how. Okay, so what is fertility preservation? We all know it is freezing of genetic material, which may be either gametes, embryo, or the tissue for future use, because this is need of the hour, especially for children, adolescent, and young adult. So this CAYA is a standard term, because in this group of people, the future fertility is a main concern when they come to us with malignancies in young age. So fertility preservation is very important topic. So we will discuss when, like what are the indications, and how, what are the procedures. So although this subject of oncofertility started with the bridging gap between the oncologist and the reproductive medicine people to have a topic of oncofertility, but if we see the scope of fertility preservation has gone beyond the cancer cases, because in addition it has been now being used for benign gynae conditions also, with some genetic disorders, autoimmune conditions, hematological disorders, transgender people, and last but not the least, the elective egg freezing for social egg freezing. So I'll just cover briefly all these indications, followed by what are the procedures. So all the malignant conditions, the cancers may be either extra pelvic when they are the outside the pelvic cavity, or maybe pelvic, then again pelvic, maybe either gynae malignancy as ma'am has covered, or it may be non gynae malignancy. So the main reason why we need fertility preservation is because it is because of either gonadotoxic chemotherapy or the total body irradiation, which affects the reproductive organs. So why it is needed? And again, it is not for all. It depends which type of chemotherapy we are using. Like in breast CA, mainly the alkylating agents are the one which actually affect the primordial follicles, which lead to accelerated loss of the follicles, and it affects the vascular damage to the ovary also, which ultimately these patients are at risk of premature ovarian aging. And in addition, there are some condition when patient undergoes brain irradiation or abdominal radiations, which affects the hypothalamic pituitary gonadal axis, or it affects the uterine body in terms of it leads to endometrial atrophy and thin endometrium. So but all these effects depend on what is the dose of these drugs, what is the duration of this treatment, and what was the patient age at treatment. Like if we see a 5 years old girl, if she gets only 1 gray of radiotherapy, she will be having risk of premature ovarian aging at the age of 40. But if the same girl at the age of 5 years gets more higher dose 12 gray, then she will have total ovarian failure by the age of 10. So that is why considering this age of therapy is very important while dealing with these patients who are going for gonadotoxic therapies. So briefly describing benign indications, because why these benign indications are candidates for fertility preservation, because all these indications they require immunomodulators and the drugs which affect the fertility, affect the ovarian function. So the scope of fertility preservation has expanded in these conditions of this SLE and rheumatoid arthritis, because the disease per se, because it is an autoimmune disease, it affects the ovary by causing autoimmune uveitis. And then it is because most of the immunosuppressive agents are gonadotoxic, and in addition this the disease causes a hormonal dysfunction also. And then the scope of fertility preservation has expanded to endometriosis, benign ovarian tumor, Turner syndromes, because the women with, especially the Turner mosaic ones, because Turner syndrome girls, by the time they come, mostly they have already gone into premature ovarian insufficiency. But the Turner mosaic are the very important crucial candidates, because here they have follicular pool, but they are at risk of accelerated follicular loss. So fertility preservation can be offered to them in terms of oocyte or embryo cryopreservation depending upon their marital status. And then some medical diseases like galactosemia and celiac disease, because these also affect the ovarian function. And women going for stem cell transfusion, nowadays we are getting patients who have aplastic anemia or myelofibrosis, they are going for blood marrow transplant. And then before that, because all those chemotherapies are gonadotoxic, so they have to undergo fertility preservation before undergoing this procedure. Transgender, this is also one upcoming thing which we can't ignore, because before going these procedures, these patients come to us for fertility preservation in the form of oocyte cryopreservation. So in endometriosis, why it is required? Because the disease per se affect the ovarian pool, especially with advanced stage grade 3, grade 4, with bilateral ovarian endometriomas and patient who has already undergone multiple surgeries. So it becomes very important, rather than doing repeated surgeries, we at least take out the oocytes and preserve them for our future fertility. And this is not only for married women, even the adolescent nowadays, because endometriosis is also globally on the rise disease. So we can't ignore the adolescents. So adolescents, while we understand that disease affects the ovarian follicular pool, so this option can be considered even in the adolescents also, as oocyte cryopreservation. And then hematological diseases, I have discussed that all these diseases require gonadotoxic chemotherapy, so these patients come to us for fertility preservation before going for these chemotherapies. So now coming to like this, as Dr. Nisha said, it is not like patient is coming and we are doing the procedure. It is a network which include the clinician who is the primary clinician, which may be either medical oncologist or surgical oncologist or the hematologist. And then it involves a big this paradigm of counseling, because counseling is very important. And when patient comes to the fertility consultant, it is very important that we understand what is the impact of the disease on patient's health and its treatment on the reproductive function. So first we have to choose that whether patient is eligible for this procedure or not, what is the impact of the treatment on future fertility, what are the options available, what are the issues related to cryopreservation storage, and what are the risk of pregnancy after gonadotoxic treatment. And we should tell them the alternative parenting and childbearing options also. and what is the probability, because it's very important to tell them, because usually they come with the thing with, and they think that this procedure of oocyte or cryopreservation is a part of their treatment. So we need to tell them that this is not to be as a part of their cancer treatment. It is just a backup option for fertility. So we need to tell them all the legal issues associated with the disease and with this cryopreservation of gamete and genetic material. So this is an interdisciplinary team involving oncologists, gynecologists, endocrinologists, and depending upon which specialty we are talking about. And we, very important, we need to have counselors. We should have rapid access for quick referrals, and we should have a specific fertility preservation team. So, coming like when the patient comes, what are the factors which will decide whether this patient is eligible or not? So, we need to assess what is a general condition, her performance status, surgical risk, because there will be risk of infection, thrombosis, or hemorrhage, and what is the age, what is her parity, what is the number of existing children, and her baseline ovarian reserve, stage of disease, and what is the survivability. If the 5-year survival rate is less than more than 50% at least, then only we will go for this procedure. Otherwise, it's very important that we counsel the family and to go for alternative options. And if there is, like ma'am said, that if there is ovarian malignancy, so then definitely we will choose other option, which I'll discuss later. And extrinsic factor like nature of the predictive treatment, like whatever chemotherapy we are giving, it is very important to know that what is the risk of gonadotoxicity. And so time, availability of local resources, and funding, all these things come into picture, because 30 to 40% of patients who come to us for fertility preservation, they go back because they can't afford, because till now in our country this procedure of fertility preservation is not funded by any government, this thing. So patients have to pay, so which causes a significant financial burden on the family. So it's, so we see what is the age, time available, how much availability of partner, type and location of malignancy, and type of treatment being planned for the primary disease. So to summarize, these are the options. So if the patient is married and she has a stable partner, so embryo cryopreservation, oocyte cryopreservation if partner is not available or it is patient choice. And then we have other, like if the child is prepubertal, so where we cannot stimulate the ovaries and get the oocyte, so then the only option available for fertility preservation is oocyte tissue cryopreservation. And sometimes even the post pubertal girls or females come, adult females come to us, but the time is not available, like the chemotherapy has to be started up to after 3 4 days or 2 3 days, so then we cannot stimulate the ovaries, and because it is a time taking procedure, it takes around 12 to 14 days. So this OTC we can do. Again, IVM is also one, which is again one experimental thing. It is not very popular because of low yield rate. And then we have two things, GnRH analog and ovarian transposition. Ovarian transposition, Dr. Nisha has discussed. GnRH analog is basically a medical treatment which can be used for other methods, or sometimes other methods have not been used. So it gives ovary protection, which is called medical oophorectomy. So of these all, whenever possible, controlled ovarian stimulation followed by embryo or oocyte cryopreservation is the most preferred method, which should be recommended to every eligible woman who come to us for fertility preservation. So regarding the protocol, so we have gone beyond now. Traditionally, it is that antagonist protocol. We use a short protocol. It is the preferred one because it is less time consuming. Roughly, we need around 12 to 13 days, and for this procedure to complete. So conventionally it was like patient has come to the clinician and usually she's being called that you come on day 2 of menses. But again, now this has also resolved. For last almost 1 decade, we have shifted to the random start protocols because these cancer patients, they cannot wait. It leads to a lot of psychological stress to the oncologist and to the patient also, so we cannot delay the cancer treatment. So we have random start ovarian stimulation. It means that whenever the patient is coming, we start from the same day injections after doing our baseline investigations. It is because that the theory is now that ovary has sufficient number of follicular waves that at any time we can give injections and we can stimulate the ovaries and have good yield of oocytes and embryos. And because for these patients we don't really matter the endometrial preparation, so in whatever phase the endometrium is, it does not matter, the injections are started on the same day or from the next day. So and there is documented evidence that it gives comparable outcomes in the term of oocytes and embryos. And sometimes, as I discussed, that it's not always the malignancy, like we have endometriosis or some benign diseases also requiring fertility preservation. We can even do double stimulation also. So this will take around 3.5 to 4 weeks, but this advantage we can give that she can have 2 or 3 stimulations so that she will have good pool of oocytes or embryos for later on use. So, and then comes the question that sometimes patient has hormone sensitive tumors like breast cancer, endometrial cancer. So here we can't give them injections because the gonadotropin, when we give, it leads to very high levels of estrogen. So here also we have solution that we add them as aromatase inhibitors, which is in the form of usually letrozole 5 milligram, which is started along with the injections, and it is continued till the day of ovulation trigger. So the advantage of this is that if the E2 levels are going beyond 2000, 3000, because these are mostly young ladies, they have very good ovarian reserve, but because they have CA breast per se, so then we can't have very high E2 levels in especially the hormone positive tumors. So this letrozole will keep the E2 very low. The usually the E2 doesn't go beyond 300, 400, or max 500. So again, once we have taken out the oocytes, we again restart the letrozole, and we follow the patient till E2 falls below 50 picogram per ml, which happens roughly within 7 to 10 days. So this is how we are safe doing these procedures. So what are the disadvantages? It needs time. It is not useful in prepubertal girls because nowadays we're having the cancer burden has increased even in the prepubertal age, and with very high estrogen level there is risk of thrombosis, and this is not feasible for ovarian tumors before surgery. So, and then other controversies are in the embryo freezing are loss of autonomy, because the if there is marital dispute after this procedure, so then the embryos cannot be used or discarded without consent of both the partners, which can lead to ethical implications. So we need to counsel the couple in detail and document everything, because it is very important that reproductive autonomy of the woman should be kept, because the oocyte belong to her only. So what we can give, we can counsel the couple that either she can go for oocyte or embryo. The easy method nowadays which is advised is that half we freeze half the oocytes and half the embryo, so that patient has at least some number of oocytes by for her, under her control only, because these are genuine problems which come to us if marital dispute happens. So then is a OTC, ovarian tissue cryopreservation. This is again now no longer experimental. It is the only procedure available for prepubertal girls and women who cannot delay the cancer treatment. So this is also one standard procedure being used for fertility preservation. Again, we need to understand that criteria that the young age, no previous chemo or radiotherapy, patient should have good realistic survival, 5 year survival rate, and she should have disease which has high risk of ovarian failure, and patient should have the detailed counseling and consent before doing for this procedure, and patient should have good ovarian reserve. This is very important, that if the patient is already 37, 38, the ovarian tissue cryopreservation is not going to help her, in terms of take home baby rate after this procedure. So we need to counsel them properly that what are the outcome of these procedures. Again, in vitro maturation can be, it is basically that without stimulating the ovary, like we don't have time and we don't have facility for OTC, so what we can do in those places and those clinics, so this IVM is also one option which can be done. Here we aspirate the oocytes without stimulation, so whatever, when that this is not possible, but again this procedure has poor yield, it is not again possible and available at all the IVF centers also. Then is GnRH agonist. This is actually a method of, it is not a standalone fertility preservation method. It gives ovarian protection. So what does it do when we are giving 2 to 3 doses of GnRH agonist? It gives hypogonadism, this condition, so which leads ovaries become quiescent. There is less blood supply to the ovaries, so that is why less chemotherapy is also going to the ovaries. So the ovaries are protected, and then first dose should be given at least 1 to 2 weeks prior the chemotherapy, because otherwise it will not give benefit in terms of ovarian protection. So as ma'am Dr. Nisha said that definitely there was one question that ovarian cancer, the fertility, this oocyte fertility preservation is not possible, but people are trying. So this is the 6 cases have been reported. Now this is the final case where they have reported pregnancy also. So here this is the combined efforts of oncologist and the reproductive medicine consultants. The first case has been reported. This is ex vivo retrieval. So this is basically for ovarian tumors. See, because in ovarian tumors we cannot do vaginal pickup unless, as ma'am said, because it will upstage the disease. We cannot do pickup if there is tumor in the ovary without before confirming the and doing the fertility sparing surgery. But here they have done this. What do they do? They stimulated the ovary, give the and for this patient had ovarian tumor. This was a patient's report. She had CA125 around 900,000, but in addition to this tumor she had around follicles also normal. So they stimulated the ovary. When the follicles were ready, they gave the trigger, and on the day of pickup she was not, the oocyte retrieval was done ex vivo. She was taken to the OT, ovaries was removed, it was given to the reproductive medicine consultant, and they did ex vivo pickup and froze the oocytes. So 13 oocytes retrieved, they could, and their pregnancy has been reported. So this is one thing which is new in fertility preservation for ovarian cancers. So then next dilemma and problem comes, the minors, and whether we should do the procedure depending upon the severity of the disease. And another problem is posthumous use of gametes, embryos or tissue, because in the prepubertal boys and girls the tissue cryopreservation is the only option. We cannot do any other method. So that is one thing which we need to keep in mind. But in adolescent girls the procedures are possible. We can do said cryopreservation, but if we think that a 14 years old girl, she has attained menarche, and we know that globally there has been shift now early menarche, and the growth spurt is happening early, but the child is not sexually mature to understand the procedure. So we can't do really these procedure in 13 14 years old girl, this oocyte cryopreservation, because it is a transvaginal ovarian puncture. It is invasive and it will need meticulous counseling because the sexual immaturity of the child, so which can lead to psychological, ethical and legal issues. So for these patients also we have option of OTC also, which should be done as a method till patient is sexually understandable and sexually mature to understand the procedure. And the communication is very important, especially when we are talking about these adolescent girls, very that we check the age, developmental level, emotional maturity, and it should be that involve children in the decision making process, inform them and then talk to the guardian and the parents so that the whole family understand the procedure. And another problem is that consenting, these adolescent girls, definitely the consent is not valid for less than 18 years, but we should involve these adolescent girls in taking assent, which is valid for any patient who is postpubertal. So, and these procedures are done only in clinics with the proper institute approval only. And then posthumous use is again in-depth counseling and utility after the death of the patient is very important. The only right is the surviving spouse or the parents, but it should be documented by the disease consent before the procedure is being done. And then another, this new thing is transgender men, because these are girls who are becoming transgender men, but they come for fertility preservation counseling and they want to go for oocyte cryopreservation or OTC or embryo cryopreservation. So this is again an upcoming thing which we can't ignore and we need to understand. And again in these patients the problem of fertility preservation is that the moment we give them estrogen, because they're already on testosterone, the levels will go down, they will again lose their virilizing features, so which can lead to transgender the trauma. So here also we add letrozole. So letrozole is one wonderful drug which we use in most of the fertility preservation procedures, because it controls the E2 levels to go high. And again, but these things we are doing only according to the law, and only if they are eligible by the law, only then these are to be done. And then planning pregnancy after gonadotrophic treatment, again it is very important that counseling is very important. These are high risk pregnancies, whether they have received chemotherapy or radiotherapy, there should be at least 1 year interval between the treatment and the pregnancy. And tamoxifen should be stopped at least 3 months before attempting pregnancy. So it is very important that we optimize the general health and endometrial preparation for these girls. So to conclude, these services are mostly underutilized. So all the patients are at loss of fertility. So any patient who is young patient, these children, adolescent, and young adults coming with cancer, they should be managed with interdisciplinary collaboration. and with controlled ovarian stimulation followed by ooset and embryo freezing is the most effective method, but we have other things also. So, and in addition, third party reproduction including donor gametes and surrogacy or adoption should also be provided while counseling these women. Thank you so much. Ma'am, you are mute.
Yeah. I just want to say a big thank you to Rita for such an enlightening talk and
Thank you,
addressing
ma'am.
the nitty-gritties of such an important subject. Um, can I request the admin to unmute Dr. Padmaja? She will be happy to discuss. Admin, please. Shivam, can you please
Yeah.
unmute
Done, ma'am.
Dr.
We've done that.
Padmaja?
That was a wonderful talk, Dr. Rita.
Thank
Uh,
you, ma'am. Thank you, Dr. Padmaja.
one more thing is like now we are having a decreasing age where aggressive breast cancers are there.
Yeah, yes,
So
young girls, yeah,
young people,
yeah,
so a career, a woman who's at the top of her career finds a partner,
yeah,
decides to settle down, has one baby, thinking of the second, and then she's diagnosed as breast cancer. This has happened to so many celebrities, so many people. If you just look at that, it happens.
yeah.
And that is one situation where all the so can you also just say a few words about that?
Yeah, because so if these patients are definitely they should undergo ovarian or embryo cryopreservation. So fertility, if the patient wants to have one more child
Hmm.
or she is nulliparous, so definitely we should not ignore it.
Hmm. So,
And
yeah, please.
no, no, ma'am, definitely it should be done because it is just matter of 12, 13 days. Like yesterday only one captain dentist has come to us. She joined 6 months back.
Hmm.
Unmarried girl, 25 years. She has been diagnosed with CA breast
Hmm.
advanced stage. So the day they come, we start them on injections or the next day.
Yeah. So for them also you give letrozole.
Yes, yes, ma'am. All CA breast we give letrozole, all CA endometrium because we have CA endometrium also those who are on megestrol acetate for months and then till their histopathology comes back. So again, we will stimulate them also with letrozole based stimulation.
So yeah, because now obesity is increasing, PCOS
Yes,
is increasing, quite a large number of them are anovulated right from
yes,
their menarche.
yeah, 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 ma'am. Mm.
And they're quite happy with amenorrhea, in fact. So,
Yes,
and
they
then
don't come back, but this amenorrhea is very dangerous. But we have seen in our series, the more the amenorrhea,
yeah,
worse is their condition, more the BMI, more they are at risk of hyperplasia and malignancy.
yes. So that is one
So
thing.
that is
That's
one
true.
thing I think we
Very
all need
right.
to push this.
So I think like now the oncology also should have like how they used to sell in our previous chapters that endometriosis and adenomyosis when we started studying was a 1.5 page chapter with adenomyosis having a small
One
paragraph.
paragraph, yes.
Now we have textbooks and conferences on that. So,
Yeah,
like that, we should slowly start getting the oncology people to look at women as not just a person carrying a tumor which needs to be destroyed. It's a woman who might have a life later on in life. So, we don't know how their
Absolutely.
requirements change.
yes,
So, we
Absolutely.
start getting, I mean, because at that point of time, the clients are so shocked that I mean, how is it going to be? Their life is shattered. They're not really thinking about fertility in the long run. It is going to happen down the line at 5 years down the line. And by then, they would have already lost the opportunity. So I
So,
think,
Dr. Padmaja, nice to have you here. And it's like, so here I would add, it is one extreme. I mean, not an extreme. It is an acceptable thing. We know that these young women, and but then the challenges are too many. We are
yeah,
still getting so many patients who are post-operative diagnosis. They already had a hysterectomy, and then they're coming with the diagnosis. CS cervix. Nobody is looking at the
okay.
cervix and just removing top of the uterus. I mean, it is such a wide variation in the way we get the patients treated here in our country, and then we have to. But and despite having so much knowledge, so many people who can do so much more to them, this is happening. So we really need to create awareness about all this.
Yeah, so I think in the oncology, one of the post standees should be, are you thinking about the future? Talk to us, something like that.
Very well said.
So
Yes,
what's a
very,
very
very
simple
well said.
thing?
Yes.
Ah,
And
and
actually, there is a lot that can be done. It's just that the doctor knows it. That's why I said first the doctors have to
Doctor,
be
yes,
aware,
ma'am.
and then the
I
clients will
think
be aware.
I think we are on the right track. Right now, we're talking amongst the gynecologists, and we all are going to be torchbearers who would be talking to the oncologists and oncosurgeons.
True.
And this kind of a standee coming up in every oncology conference. I think the drug company people who help us organize conferences can actually put up standees there and then make the people aware. Maybe we could have a kind of a kiosk where one of us could be there and guiding people. Thank you so much, Dr. Nisha. Thank you so much, Rita and
Thank you,
Padmaja
ma'am.
and Divya and Parul for taking us through this. And I think now is time for us to move on to the quiz. And over to you, Divya.
Yeah, I think now we are all ready for the quiz. Mr. Shivam, let's all please join for the quiz and everybody please
Divya,
install the
please lay
Kahoot
out
app.
the rules first. Divya, please
Yeah,
guide
yeah,
them about the rules first.
yeah. Everybody who is interested to participate in the quiz, please join the Kahoot app on a home screen. Then you can see the button, join button at the bottom of your screen. Join with it, and the game pin is already mentioned on the screen. You can see that game pin. You can join and don't use your mobile number at the nick place.
No,
Nickname
you have
place.
to use their mobile numbers. Divya, we
Yeah,
want
use
them
the
to use
mobile
their
number.
mobile numbers.
Yeah, use the mobile number. Yeah, the people are
And one
joining.
more thing, the speed and the accuracy both are
Accurate.
important. We would request you girls and boys to be really fast and be accurate because both the things matter.
Yeah.
Shubhra Singh, please don't type your number here. You join with this number.
Number.
Shubhra, join with this number.
Neha
Once we
also
have
your
all
phone
of you
number.
on board, once we have everybody on board, we would lock the quiz
Neha,
room.
Neha, I could see your name. Please join your mobile through your mobile number. Put your mobile number over there.
Yes.
Yeah. All
Yes.
of you, please join through your mobile number. The game pin is already mentioned on the screen. I think 17 people have joined.
NP, please join with your mobile number.
NP. Please put your mobile number over there. I think
NP, can you hear me?
Yes,
yeah,
that's right.
Yeah, it's okay.
No,
again,
no.
NP is mentioned. NP, please put your mobile number instead of your initiative.
It will be difficult for us to reach out to you. You'll be getting prizes and certificates, and we need to collect the names of the winners because the winners would be moving on to the finale. So we really need your mobile numbers rather than the names which we can't identify.
Still, then it has not been changed. NP.
Dr. Rita, I said there's a question here. Should we offer fertility preservation to a girl with dermoid, unilateral or bilateral?
Dr. Rita, by the time people are joining us, please, will you be happy to take this question?
Yes, ma'am. Yes, ma'am. I'm replying to that question.
Okay.
Yeah.
We have 19 people so far. Divya, should we wait for another 1 minute to let people join in?
I think so.
Because there are
Maybe
33
almost 20 people
participants.
have joined.
Yeah.
One has left or what? Twenty people have joined.
Shubhra, are you in? I think you are in.
Yeah, she's in.
Okay. So, Shivam, do we lock the Kahoot room and do we take off? Yeah.
So everybody be ready for the quiz. And the first question is, the only established method of fertility preservation for prepubertal female is? Your option is oocyte cryopreservation, ovarian tissue cryopreservation, in vitro maturation, and gonadotropin releasing hormone agonist, GnRH agonist. Should I repeat the? You can see. Yes, the scoreboard is there. 8765. Yeah, they are at the top. Now the second question is, which is not true about the oocyte freezing? The option is the oocyte retrieval rate is 83% and live birth rate is 35%. It is associated with zona hardening, results in permanent loss of spindle integrity and higher incidence of congenital anomalies. Yes, the answer is higher incidence of congenital anomalies. Because the studies have shown there is not much difference between the two, between the normal cycle, normal conception, and those who have conceived through oocyte freezing. The third question. Regarding the fertility sparing surgery for the young, unilateral salpingo-oophorectomy can be considered in which condition? The stage 1A dysgerminoma, stage 2A epithelial ovarian tumor, stage 1B sex cord stromal tumor, and stage 1C serous adenocarcinoma. Yes, the correct answer is stage 1A dysgerminoma because it can be done in the early stages of the carcinoma. Dysgerminoma. Now the scoreboard has changed. The next question, the following protocols are preferred for ovarian stimulation in cancer patients undergoing fertility preservation. And GNR accept, the question is accept, GnRH antagonist, long protocol, random start, and double stimulation. Yes, the answer is long protocol because we don't have time. We have to start and the patient has to go for chemotherapy or radiotherapy. And the highest scorer is 8765. Yeah, they are at the top. Which is not the criteria for radical tracheotomy. Desire to preserve fertility, tumor size less than 2 centimeter in diameter, cervical cancer in stage 1B2 and stage 2 stage 2, and absence of distant metastasis on MRI. Yes, the correct answer is cervical cancer stage 1B to stage 2 because it can be done only till stage B1, IB1, first B1. And the topper is, next question. Which of the following is true about the use of GnRH antagonists for ovarian stimulation in cancer patients? The answer is afford more flexibility, causes the lower estradiol rise, lower gonadotropin dose needed, and all of the above. Yes, the correct answer is all of the above. Now this next question is, in which condition ovarian tissue cryopreservation is not a reasonable choice for fertility preservation in pre-pivotal girls? Those who are planned for cancer chemotherapy, ovarian malignancy, girls with low ovarian reserve, and planned for cytotoxic therapy for severe SLE. The correct answer is girls with a lower ovarian reserve. Next question is, which method is mostly used for ovarian tissue cryopreservation for fertility preservation? Vitrification, slow freezing, vitrification followed by slow freezing, and none of the above. Yeah, buck up. You can still catch up. There's still lots of confusion. Yes, the answer is slow freezing, because vitrification is preferred in cases of oocyte and embryo freezing, but for ovarian tissue cryopreservation, the slow freezing is preferred method. Ovarian tissue transplantation at the heterotrophic site can achieve the conception through the following method except in vitro fertilization, ICSI, natural, and IMSI. Hurry up. Speed is equally important along with accuracy. Yes, because heterotrophic site, the patient cannot conceive by a natural method. Which drug is offered for ovarian function protection in premenopausal breast cancer patients receiving chemotherapy? The options are GnRH antagonist, GnRH agonist, letrozole, and tamoxifen. Yes, the answer is GnRH agonist. Up to 3+. Yeah. The transposition of ovary is indicated in the following indications except pelvic radiotherapy without chemotherapy, early stage cervical cancer, patient receiving concomitant chemotherapy, and young patient with Hodgkin's lymphoma undergoing radiotherapy. Look up. The correct answer is patient receiving concomitant radiochemotherapy, because chemotherapy can be gonadotoxic. So transposition of ovary is not going to help. In ex vivo ovarian tissue oocyte in vitro maturation, cumulus oocyte complex, they can be collected from all except from the excised ovarian tissue, spent media during the ovarian cortex preparation, Graafian follicle, and oophorectomy for the organic ovarian cyst. The answer is Graafian follicle, because we are talking about the ex vivo as well as the in vitro maturation. Which chemotherapic agent has highest risk of causing premature ovarian insufficiency? Cyclophosphamide, cisplatin, doxorubicin, and 5-fluorouracil. Yes. Although all the chemotherapeutic agents, they are gonadotoxic, but the cyclophosphamide, there's the highest risk of ovarian causing the premature ovarian insufficiency. Next. Next. Yeah, this is the scoreboard. The estimated radiation dose found to be sufficient to destroy more than 50% of human primordial follicles in adult. 5 gray, 10 gray, 2 gray, and 1 gray. The answer is 2 gray because the studies have shown even the 2 gray is sufficient to destroy more than 50% of the follicles. Which drug is not used to reduce the estrogen level in COS protocol in women with hormone sensitive cancer undergoing fertility preservation? Letrozole, exemestane, clomiphene, and tamoxifen. The correct answer is clomiphene because the mode of action of clomiphene is different. It does not reduces the level of estrogen, but it blocks the receptors. In orthotropic transplantation of an ovarian graft, the graft is transplanted into brachioradialis fascia of the forearm, under the rectus sheath of the lower abdomen, near the infundibulopelvic ligament and the anterior abdominal wall. Yes, the answer is near the infundibulopelvic ligament because in orthotropic transplantation, it is the transplantation is done inside the pelvic fossa only. How much of its follicle reserve the ovarian cortical graft generally loses because of post-transplantation ischemia? The option is 1/3, 2/3, half, and 1/4. The answer is 2/3 because after the transplantation, because of the this ischemia, almost 2/3 of the follicle reserve is lost. Heterotropic transplantation may be ideal for individuals seeking fertility, return of hormonal function, ovulation stimulation, and successful follicular growth. Yes, the answer is return of hormonal function because the only 1 or 2 pregnancy has been achieved after the heterotropic transplantation, although it can be good for return of hormonal function. Which of these is incorrect regarding use of exemestane in breast cancer? It is a potent aromatase inhibitor used along with GnRH agonist in estrogen receptor positive premenopausal women, helps to preserve the fertility by causing ovarian suppression, and used for early stage disease in postmenopausal women. The correct answer is it helps to preserve the fertility by causing ovarian suppression. This is the wrong answer because the GnRH agonist basically helps to protect the ovarian protection. Ovarian tissue preservation is not an option for women with BRCA1 and 2 carriers, hormone sensitive tumors, planned for chemotherapy, and colorectal carcinoma. The correct answer is BRCA1 and 2 carriers because these patients, they are at risk of the ovarian malignancy. That's why they are not preferred for the ovarian tissue cryopreservation. Yeah, the scoreboard. Yeah. And the first is, they have given 16 out of 20 questions. They have done it correctly.
I would request the winners to please put in their names and email addresses in the chat box because we need to give them these certificates which would be given by the email. All the winners, all 3 of you, please put your names and email addresses in the chat box.
Yes. And big applause for the winners. Keep it up. Winners, please put your name, mobile number, as well as email ID in the chat box. You would receive the e-certificate through your IFS from IFS.
Dr. Manjusha, this quiz is open for all over the country, no?
Yeah. We have been I have been sending messages to all the groups and requesting everybody to be sending messages. I was expecting hundreds of participants, but somehow I don't know why we are not gaining popularity. I think kids can tell us better what kids expect and how they
Yeah.
want us to work.
Quite a large number of them, they're doing the post-graduation. So maybe the youngsters are busy with their careers, families and all that. So
I think this quiz is going to help in their studies also. So
yeah,
the-
I find it very illuminating. So
yeah,
many times I think I know things now, especially that one, that two-third of the follicles are lost. So we are
yeah,
advocating it so much, and when you realize two-third are lost, then how much hope are we really offering them?
yeah.
So yeah,
There are so many new things to learn. Even
yes,
we are learning.
yes.
Actually,
I think people
all
they
I
have,
can say is that we really learn from making the quizzes. I really
yeah.
wish
If
the
you
children
are
also
making the
learn
quizzes, you
something.
have to read it properly. Then only you can make the quizzes.
Yeah. If
Yeah.
any of the girls here, girls or boys in the participants have any feedback or any comment or anything, uh, any suggestion so that we can incorporate that in our future events.
Yeah, I
Because
think
we have
others can be allowed to unmute now, everyone, because the talks are over.
yeah, admin, can you unmute everybody? Dr. Sajad is with us. Yes. Hello, Dr. Sajad.
Yeah.
Thank you for opening up your video. We could not see your face. You have been with us, but we could not see you earlier.
It's
Yeah, I can see
muted.
Yukti here. Yukti, would you like to give us some feedback about how you want this program to go on or whether it is benefiting you?
Yeah, Dr. Said, you're
Yeah,
unmuted.
yeah. Good evening, everybody. There.
Mm.
As we come to the end of this insightful and intellectually enriching session of fertility preservation, it is my privilege to deliver the concluding remarks and extend a heartfelt vote of thanks to all of you. Today's program has been a remarkable journey through evolving concepts, clinical applications, and future perspectives in the field of fertility preservation. The two thought-provoking and informative talks provided us with deep insights into the importance of early intervention, patient counseling, and the latest advancements in preserving fertility across different patient profiles, including cancer survivors, individuals with genetic risks, and those undergoing gonadotoxic therapies. We also had an engaging quiz session that not only tested our knowledge but also reinforced key learnings in an enjoyable manner. A big thank you to all the participants for their enthusiastic involvement. On behalf of the organizing committee, I express my sincere gratitude to our esteemed speakers for their time, wisdom, and dedication in enlightening us today. Your contribution have truly added immense value to our academic understanding and clinical practice. Thank you to the organizers, IFS President, our worthy Dr. Pankaj Talwar sir, our worthy General Secretary Shweta Mittal ma'am, and the great our Professor Dr. Manjusha and the Indian Fertility Society for their support. Thank you all. Thank you.
Thank you and good night.
Thank you so much, sir. Thank you. Thank you. So I think before we wind up, let me just give a message about the next event. The next would be on the 17th of July. And the topic would be poor ovarian reserve and ovulation induction. I'm yet to work out on the speakers and the exact topic. And the quiz would be conducted by none other than Dr. Padmaja, who is an avid quizzer and avid quiz master. So we look forward to all you girls and boys, all the fellows, residents, everybody in our next session on the 17th of July. Same time, we'll be sharing the link soon with you. Thank you all. Thank
Thank
you.
you. Good night.
Thank
Bye-bye.
you.
Thank you.
Bye.
Thank you, sir. Thank you so much, sir. Thank you.
Thank you.